Hello everyone, I am Dr. Ektha Pai, Senior Lecturer, Department of Prosthodontics, Yenepoya Dental College. Today I am here to give you a few insights into resin bonded bridges. Now when we hear the term resin bonded bridges, we obviously imagine the resin cements and the composites or a provisional restoration. But let me tell you, we can use this as a permanent prosthesis as well. Imagine a patient walks into your clinic with a single missing tooth. The first thing that will come to our mind is replace it with an implant. The second thing would be a fixed dental prosthesis or a fixed partial denture. Now I am going to give you a third option, that is a resin bonded bridge. Let us see what this is today. Now by the end of this session, you should be able to understand the concept and significance of resin bonded bridges. You should be able to classify them, understand the advantages and disadvantages of resin bonded bridges, and also apply all these knowledge into the clinical scenarios in treatment planning, patient selection and restoration placement. Now simply put, resin bonded bridges are replacement of missing teeth with maximum conservation of tooth structure. Now we know how important the enamel is to the tooth structure, and when we are planning an FPD, we know how much amount of enamel has to be removed in order to provide a single missing teeth. So resin bonded bridges to some extent provide a solution for this problem. By definition, resin bonded bridges are a fixed prosthesis or a fixed partial denture that is luted to the tooth structures, primarily the enamel, which has been etched to provide micromechanical retention for the resin luting agent. This definition has been given in the Glossary of Prosthodontic Terms, edition 10. Now that we know what a resin bonded bridge is, let's see where these resin bonded bridges are indicated. When you have a single missing incisor or a single missing molar, you can consider this when the abutment teeth are caries free and they are properly aligned. Also, it should be a short span edentulous space. You can also use this in children and adolescents or in orthodontic cases when there is missing teeth and you need to maintain that missing tooth space to provide a definitive restoration in the future. You can also use these resin bonded bridges as a periodontal splint when there are mobile teeth present. You can use this in prolonged placement or as a long-term provisional for correction of craniofacial anomalies. The whole point in all these indications, the major point would be that there should be sufficient enamel to etch. Moving on to the contraindications, or where you cannot give a resin bonded bridges, the first one would be sensitivity to base metal alloy. Of course, we have different types of materials that can be used in a resin bonded bridge which does not require a metal alloy, but most of the bridges contain metal and you cannot use them in patients who have sensitivity to base metal alloy. Now, you cannot give in cases where the facial aesthetics of the abutment tooth needs to be changed, or even in diastema cases because the prosthesis is placed in the lingual portion of the tooth and not in the facial surface. So, if you need to change the aesthetics of the abutment tooth, you have to give full coverage crowns. You cannot give in long span edentulous spaces or deep overbite cases because there will be too much stresses on the retainers of the resin bonded bridges which may lead to its fracture. You cannot give in patients who have extensive caries or restoration because again it is going to reduce the enamel structure or the amount of enamel that we have to etch or bond to the resin bonded bridge. Now to classify resin bonded bridges, you can either classify it based on the materials used or the type of adhesion or the bonding that the resin bonded bridge does to the tooth. So we have the mechanical retention, the micromechanical retention, macromechanical and the chemical adhesion. Now according to this, under the mechanical adhesive bonded bridges, we have the bonded pontic as well as the Roused bridge. Under the micromechanical, we have the Maryland bridge. Under the macromechanical adhesion, we have the Virginia bridge, and under chemical adhesion, we have the adhesive bridge. Let's talk about each of these types of bridges. Moving on to the bonded pontics. In this, an extracted tooth or an acrylic tooth can be used as a pontic, wherein it is adhered to the proximal and lingual surface of the adjacent tooth. You can either use a fiber splint or ligature wires, or you can prepare slots on the adjacent tooth and bond it with the composite resin. It is a short-term replacement and has a limited lifetime, so you cannot use this as a definitive prosthesis, but you can use it as a temporary prosthesis. It is easy to fabricate, so you can give this even in implant cases where you have to place the implant, you have to submerge the implant and maintain that space for a long period of time till the implant heals. Moving on to the Roused bridge, it was the first definitive prosthesis that was introduced by Roused in 1973. It is also known as cast perforated resin bonded bridge. Now it has a metal ceramic pontic with two wing-like retainers with funnel-shaped perforations. Now these perforations on the surface where the retainer etches and bonds to the tooth will have a smaller diameter, and on the facial surface it will have a larger diameter. So it is cemented with composite resin with a mechanical retention. You can also use saline coupling agents for additional retention. Now the disadvantages of the Roused bridge is that it is exposed to too much of external stresses. It has marginal leakage because the structure of the Roused bridge is such that the margins do not adapt well to the tooth structure. It has limited addition as it is only mechanical retention and there is no bonding of the bridge to the tooth structure. It is also subjected to a lot of abrasion because of its bulky nature. Moving on to the next type of resin bonded bridge, that is the Maryland bridge, which is most commonly used resin bonded FBD. It was introduced by Livatidis and Thompson in 1980. It has a non-perforated metal retainer. We have to use resin cement for bonding this structure. The advantage is that it has good retention and the disadvantage is that it is expensive and technique sensitive. Now why it is technique sensitive? Let's see the technique of bonding of Maryland bridges. Now to bond these non-perforated retainers, the retainer has to be coated with paraffin wax in areas where the bonding should not happen. Then we have to etch the metal retainer surface with 3.5% nitric acid. Then we have to place it in a bath with 250 milliamperes current for 5 minutes, and you should immerse it in 18% hydrochloric acid in an ultrasonic cleaner for 10 minutes before bonding it to the adjacent tooth structure. Moving on to the next type, that is for the macromechanical bonding, we have the Virginia bridge, which was introduced by Moon and Huygens in 1983. It has visible macroscopic mechanical undercuts. For this, we have to create these mechanical undercuts. So we can either have it as a cast mesh or we can use the lost salt technique. Noble metal alloys are used in this, and surface treatment of the retainers are not necessary because the surface treatment is already done, or it already consists of the macroscopic elements that need to be bonded. So we do not have to create this by etching the retainers. Now in the lost salt technique, we use 150 to 250 micrometers crystals of salt on the tissue surface of the cast. Now once the salt is placed, we place resin over it and make the pattern of the retainers, and then the salt is dissolved in an ultrasonic cleaner. Now this salt, when it dissolves, it forms voids on the surface of the retainer of the resin pattern, and it is reproduced on the metal retainer. Now in the metal mesh technique, there is a nylon mesh that is placed on the tissue surface of the retainer. The pattern is fabricated on the mesh and then it is cast in metal. The disadvantage of this is that it is very difficult to adapt the mesh, and if the wax flows into the undercuts, it will block the mesh that we require for the bonding process. Now moving on to the adhesive bridges, the resin cement is bonded to the metal surface. The advantages of the adhesive bridges is that it has high bond strength, the fracture toughness is high, and there is good clinical success. The materials that can be used to bond the metal to the tooth structure are the modified BIS GMA cement with adhesion promoter. You can use super bond, which has highest initial bond strength and low elastic modulus, high fracture toughness. The third system that you can use is the Rocatex system, which has to be air abraded with silica carbon, and then selenization has to be done. The last material that you can use is the Panavia, which has excellent bond to the base metal alloys. Another technique that you can use to bond the metal retainer to the tooth structure is by chemical etching or tin plating. Now in the chemical etching, you have to use a gel that consists of nitric acid as well as hydrochloric acid and is applied on the internal surface of the retainer for 25 minutes. The second type is the tin plating, where the tin plate forms organic complex with several adhesive resins, and it can be used with noble metal alloys as well. The results are significantly greater bond strength and give a good strength to the resin bonded bridge. Now moving on to the advantages of resin bonded bridges. It is minimally invasive, as the definition says. We require to prepare very less enamel structure, that too on the lingual surface of the tooth. So there is no LA required and no need of provisionals. It is easy to make the impression as well. You can rebond it in cases of debonding. It requires less chair time, and the cost of making these resin bonded bridges are less because less material is used, and finally it causes less periodontal irritation when the patient maintains his oral hygiene. Now moving on to the disadvantages of resin bonded bridges. It is very technique sensitive, and if the technique of bonding to the tooth structure is not followed, the debonding of the resin bonded bridge takes place, and it may also cause plaque accumulation if the design is not correct. It has a bulky design, so may cause irritation to the tongue. It is not ideal for replacing more than one missing tooth. The uncertainty of its longevity makes it less of a permanent restoration and more of a temporary restoration as perceived by general dentists. And no space correction and alignment correction is provided by this resin bonded bridge. For such cases, you require a full coverage crown. Now moving on to the method of fabrication. The first thing will be to prepare the abutment tooth, design the restoration, and finally the bonding of the restoration. Now moving on to preparation of the abutment tooth. The principles of preparation would be that there should be a distinct path or direct path of insertion. There should be no undercuts in the proximal areas. We should provide an occlusal or cingulum rest. There should be a wraparound preparation, which means there should be 180 degrees of tooth preparation to provide greater area for the retainer to be bonded to the enamel structure. The margins should be placed supragingivally, and the proximal groove or slot has to be provided for additional retention. Now for the anterior tooth preparation, use the largest area possible on the lingual surface of the tooth. You can provide cantilever design, especially when the lateral incisor is missing. Supragingival margin is preferred with the 1 mm chamfer finish line. Now in the anterior tooth preparation, we will use a wheel bar to prepare the lingual surface, and then we are going to prepare 0.5 mm slots just to provide additional retention. Now the preparation is extended to the margin, which is 2 mm away from the incisal edge on the proximal areas, and finally additional retentive features are given and the proximal surface of the tooth. In the posterior tooth preparation, we again have to give a wraparound preparation, that is 180-degree preparation, or as you can see in the first picture, the occlusal surfaces can be prepared. Then we have to prepare a spoon-shaped occlusal rest if we are giving a wraparound preparation. The interproximal surfaces must be parallel to each other and a retentive slot has to be provided. In the case that you can see right now, the molar has been prepared for a inlay retained preparation and a occlusal preparation has been done in the premolar region for better retention. Moving on to the bonding of the restoration, the composite resins are used to bond the metal framework to the etched enamel surface. Conventional bis GMA resins have been replaced by the recently developed resin metal adhesives, for example the Panavia. Now in this we need to use an oxygen barrier at the margins, and then it has to be air abraded with 50 micron aluminum oxide. We can use tin plating and metal primers for the noble metal alloys. The use of silica coating enhances the bonding, and rubber dam isolation is a must to reduce the risk of debonding. Now moving on to the bonding procedure, the tooth surface that has to be bonded has to be cleaned with pumice and water, and the enamel has to be etched for 30 seconds. Apply the primer for 30 seconds and dry it. Now apply the luting cement to the fitting surface of the restoration or the retainer and seat the restoration with continuous pressure. Now remove the excess cement and apply OxyGuard and light cure. Now once the cement sets, remove the excess OxyGuard and rinse the structure. These are two clinical cases, one wherein two pontics are used as a splint or a periodontal splint in the lower anterior region, and the second case shows in an orthodontic case to maintain the space a Maryland bridge has been used. Post-operative care, how the patient has to take care or how a dentist has to take care of a resin bonded bridge. First of all, regular checkups are necessary. You can do it by gentle pressure with a sharp explorer at the edges. Patient should be warned about the complications that can happen in a resin bonded bridges, that the debonding can happen, about their periodontal health, how their oral hygiene has to be maintained, and in case of debonding, you can clean the tooth structure as well as the retainer with air abrasion, acid etch, and rebond the resin bonded FPD to the tooth structure. Now why failures happen in resin bonded bridges? There can be three causes. The first one is the inappropriate selection of the patient or the case, wherein there are malaligned teeth, there is insufficient enamel to be etched, there is insufficient vertical height or labiolingual surface, and the patient has metal sensitivity. The second cause is inadequate or improper tooth preparation. Like I said, there should be wraparound preparation and at least 180 degree of the tooth surface has to be prepared. The third one is the bonding failure. It can happen due to contamination and improper isolation. So rubber dam isolation becomes a must when you want to cement the resin bonded bridges. Now moving on to conclusion, a careful selection of cases is very important for the resin bonded bridges to be successful in a long-term scenario. You can use it as a provisional restoration only if there are no ideal conditions. Otherwise, you can always use it as a long-term prosthesis if the cementing procedure or the bonding procedure is done under isolation, the preparation is done perfectly well, and there is a large area of enamel that can be bonded to the tooth structure. Moving on to the summary of this session, we know what is resin bonded bridges now. We know what are the indications and contraindications of resin bonded bridges, the advantages and disadvantages, the individual designs or individual types of resin bonded bridges that we can give as options to our patients, the type of tooth preparation that has to be done, and the procedure for bonding the resin bonded bridge to the tooth structure. We also know what failures can happen if we do not follow the correct protocol in luting, preparation, design of a resin bonded bridge. These are my references. Thank you.